Thank you for having me. And I always appreciate when Gary Bloom sends me the email and invites me to come. I love coming to ThyCa. I feel like I'm a part of ThyCa, so I feel right at home when I come here. So I'm going to talk to you today about differentiated thyroid cancer and the general treatment of differentiated thyroid cancer, as well as when it's okay to have disease and watch and wait. I think for recording purposes, they want you to save the questions for the end, but otherwise it's pretty informal. And I made the talk fairly short, so there should be plenty of time for question and answer. Can everybody hear me in the back? Okay. So these are my relevant financial disclosures. I do a lot of research with a lot of companies, and I sit on the board so that we can get drugs FDA approved for thyroid cancer. So these are my financial disclosures. So thyroid cancer, the incidence of thyroid cancer is increasing worldwide. That means there's new cases of thyroid cancer every day. It's one of the few cancers that continues to rise for unknown reasons. And initially people thought that this was because now we have better techniques of picking them up, ultrasounds, and that would imply we're picking up smaller tumors. But the larger tumors are also increasing in size as well for unclear reasons. And it's climbed to the 5th most common cancer in women. Shown here, just in 2010, 2009, it was the 8th most common cancer, and now in 2015, it's the 5th most common cancer. So there's 4 types of thyroid cancer. Papillary thyroid cancer, which is shown at the top, is the most common, making up about 75 to 80% of all thyroid cancers. Follicular thyroid cancer is the second most common and occurs in about 10 to 15% of all thyroid cancers. Medullary and anaplastic, thankfully, are very rare and are not going to be the subject of the talk today. Papillary and follicular thyroid cancer together is what we call differentiated thyroid cancer, and throughout the talk I'll be referring to that as DTC, or differentiated thyroid cancer. So there's about over 60,000 new cases every year of thyroid cancer, but the prevalence is almost at 500,000, which means there's 500,000 people walking around with thyroid cancer. It makes up about 4% of all female cancer survivors, but thankfully the deaths from thyroid cancer are under 2,000. So there's some questions that I want you to think about, and we'll raise these up again in the end, and we can talk a little more about it at the end. Your goals, what your individual goals for the treatment of your thyroid cancer should be personalized to what you are looking for and the information that your physician gives you. So I want you to think about what are your goals, what are the side effects for the different treatments that the doctors are talking to you about, how many surgeries or radioactive iodine treatments have you had, and how many thyroid cancer surgeries has the surgeon that you're seeing done, and how much thyroid cancer does my endocrinologist or my oncologist, depending on who you're seeing, actually see. These things are important throughout your treatment, especially in people who have thyroid cancer that has come back and they're dealing with recurrent or persistent disease. So at the time of the diagnosis, if patients who have smaller tumors, you want to know, okay, you're saying you want to take out my thyroid cancer. Are you going to take out half a thyroid, the whole thyroid? Do you need to take lymph nodes out? Why, and what's the evidence to make that right or wrong? And then after my surgery is out, do I really need radioactive iodine? And if I do, why? What are the goals, and does it really help? Or is it just easier for you as a doctor to follow me? And then when you give me my thyroid hormone, what is the goal that my levels of my thyroid hormone, or what's known as TSH suppression? So let's talk a little bit about all those things. So differentiated thyroid cancer comes as a 3-pronged treatment, and we're going to talk about each of these individually. So surgery is the first treatment and the best chance at cure. And there's different words that they throw out there for surgery, and we'll talk a little bit about those. And then radioactive iodine is the second pronged treatment, and we'll talk about why we may or may not need that. And then the third treatment is now you no longer have a thyroid, so let's give you back thyroid hormone, but we give you a little more than your body needs to keep the cancer from coming back. So it typically is surgery, radioactive iodine, plus or minus, which we'll talk about. And then if cancer comes back, it may be more surgery, more radioactive iodine, and then thyroid hormone. Okay, so let's talk a little bit about surgery. So first of all, it's very important that everybody understands that surgery is the best chance at cure. So the key to having that cure is to finding a good surgeon. So asking your surgeon, how many thyroid cancer surgeries do you do? Not just how many thyroid surgeries do you do. And it's okay to ask your surgeon that. And they might use the words lobectomy, which means removing half your thyroid. So the thyroid's a butterfly-shaped gland divided into two halves that are connected, but sometimes it's okay to just remove half the thyroid, especially if the cancer is small. I'm sorry, I wrote myself a note there to let y'all know that an ultrasound should always be done before surgery. So if you're going to have half a thyroid out, an entire ultrasound of the whole neck needs to be done, not just a thyroid ultrasound. So what that means is it's from here to here, and it should take more than 15 minutes to do your ultrasound. So you're looking at the lymph nodes, because if you have cancer in the lymph nodes and somebody goes in and just removes the thyroid, then you're going to be one of those patients that's saying, why does my cancer keep coming back? Well, it's not keep coming back, it's still there. So have a full ultrasound of your neck. So then the most common type of surgery in thyroid cancer is a total thyroidectomy, which is removing the whole thyroid. And the surgeon may or may not remove lymph nodes, depending if they saw abnormal lymph nodes on the imaging or the ultrasound, or in surgery to the surgeon's eye, they could see lymph nodes that looked abnormal. So we have about 200 to 300 lymph nodes in our neck that help us fight off infection. The cancer likes to go there. So those are the things that the surgeon's looking at. So the next step is radioactive iodine. So now the thyroid's out, so the thyroid cancer should all be removed. Maybe some lymph nodes were removed. What about radioactive iodine? So iodine is naturally used by the thyroid to make thyroid hormone. And if you trick it and make it radioactive, when you ingest that radioactive iodine, it should go anywhere in the body where there's normal thyroid tissue or thyroid cancer and burn it off. So it's considered a targeted therapy. It's targeting directly what you're looking for. And so the goal is to get rid of normal tissue, or what people call ablating the remnant tissue. So sometimes a surgeon will leave a little bit of normal thyroid there, not to damage the nerves or the parathyroids, and so that iodine will get rid of that normal thyroid tissue. It's not used if half a thyroid is still there. And then the other reason to do it is to treat metastatic disease, so cancer that has spread outside of the neck or is in areas deep in the neck. There are various doses that your doctor could talk to you about using, from low doses to high doses. Lately, the research in the last few years has been suggesting that lower doses can do just as good a job as the higher doses. So what are the goals of radioactive iodine? So the goal of radioactive iodine is not to mop up disease that's left behind, right? So it's not that, okay, I had part of, things removed and now I'm going to use the radioactive iodine to clean it up. The goal is what's called adjuvant radioactive iodine. So that means I've had good surgery, I'd have things removed, but now I'm going to use this second treatment called radioactive iodine to decrease my risk of the cancer coming back and ideally decrease my risk of dying of this disease. The issue is that many thyroid cancer patients are not at risk to die from their cancer, and they're not at risk for their cancer to come back. So the question is, do they really need this treatment? So it does make the doctor's job easier, and we'll talk a little bit about that, because there's a cancer marker called thyroglobulin that this radioactive iodine can make go down to 0. So there's lots of side effects that can occur from radioactive iodine. In general, radioactive iodine is a safe treatment. Most patients do fine and don't notice it, but there can be side effects, especially if you use higher doses or multiple doses, or if your body's just sensitive to the radioactive iodine and you have maybe some underlying other diseases. So these on the left side are some medical terms that people will use, and on the right side are just an explanation. So pulmonary fibrosis occurs mainly in people who have thyroid cancer in their lungs. You treat them with radioactive iodine, and we can affect the lungs and your breathing. But it also can help cure the thyroid cancer in the lungs. So we need to balance all these things out. Patients can get dry mouth. They can get cavities as a result of the dry mouth. You can get blocking of your tear ducts, so you still make tears, but they don't drain properly. So you're constantly tearing. And then second cancers, although it's a very low risk, there have been some recent studies to suggest it's still a potential possibility. So these are things that you want to think about when you're weighing all these things out. Now, in general, most of these things do not occur for the average thyroid cancer patient who's getting a low dose, but they still need to be thought about. So traditionally, people said, hey, you have thyroid cancer, we're going to do surgery followed by radioactive iodine. And now we're thinking about more selective use given the evidence that's coming out, meaning who are we going to try and use this in? So many what we call low-risk patients, meaning patients who have smaller tumors or small lymph nodes involved with their thyroid cancer, are at low risk to come back, especially the young female. And so the guidelines that came out from the American Thyroid Association in 2009 suggested that patients with smaller tumors should not have radioactive iodine, and yet the studies show that 30 to 40% of patients who should not get radioactive iodine by guidelines are still getting radioactive iodine. So we need to continue to get the education out there for both patients and physicians, right? So the American Thyroid Association guidelines looked quite complex in 2009. And they listed on the left-hand side characteristics of the tumor. You don't need to memorize any of this. I just want to show you 2 points. One is they talk about tumors. When you think about thyroid cancer, the size of the tumor, whether lymph nodes are involved or not, whether it was extending outside the thyroid, and whether it's gone outside. That's what's called staging. And so the goal of radioactive iodine, again, we said, was to decrease the risk of the cancer coming back and decrease the risk of dying from it. So when you look at the tumor characteristics, meaning the things that we look about in the tumor to see if patients are going to, if they're at risk for dying from their disease, a lot of these characteristics have a no next to it in terms of increasing the risk of death. But yet people were still giving these patients radioactive iodine. There are some characteristics that do increase one's risk. And so we need to think about what's called selective use of radioactive iodine. The new guidelines that will come out from American Thyroid Association, unfortunately they're delayed because they're trying to decide on details, will be more detail-oriented in who should get radioactive iodine or not. They won't be perfect because we don't have enough evidence to all agree. So the selection philosophy says, well, we can either choose or selectively use patients who should receive radioactive iodine and have the philosophy that most patients do benefit from radioactive iodine, or we could have the philosophy that in general we will not use radioactive iodine and we're only going to use it in the select few who we think it can actually help. So it depends on what camp you come from and how you interpret the new guidelines that are going to come out. So the new guidelines are going to look something like this, and this is not something that I'm doing it fast because there's no point in writing it down because they haven't come out, so that can change any minute. But it's going to have this scale of low risk to high risk thyroid cancer, and it's going to come up with some guidelines as to who should receive radioactive and who shouldn't, and to be a little bit more clear. And I got this slide from Dr. Mike Tuttle, so I want to give him full credit for that. So who should we consider not giving radioactive iodine to? So we said that radioactive iodine may not be beneficial in lower risk patients, and what do we consider that? So patients who are under the age of 45 with smaller thyroid cancers, who don't have any lymph nodes involvements, or even if they're under 45 and they just have a couple of lymph nodes in what we call the central neck, so not the lateral neck, meaning here in the center. Those patients may be at lower risk for thyroid cancer to come back, so we often will avoid giving those patients radioactive iodine. And some patients who, even though the pathology report says that there was a little bit of extrathyroidal extension, but it was small, we discussed it with the pathologist and it didn't sound like it was at increased risk. These are patients that we in general are currently not giving radioactive iodine to. So how do we prepare patients for radioactive iodine? Well, you want the body hungry for that iodine. So in order to make that body hungry for that iodine, your body has to think that it's hypothyroid. So that means that the thyroid is underactive. So you need the TSH greater than 25. There's some reports that say 20 and some that say 30. So just putting 25 there. To do that, you need to be on a low iodine diet for 1 week, which probably is the hardest thing for the patients. They just don't like it because iodine's in everything. The U.S. did a great job about fortifying all their foods. But for the thyroid cancer patient, that basically means buying non-iodized salt and cooking at home. And you can do it by what's called withdrawal, which is being off your thyroid hormone, or you can do it by remaining on your thyroid hormone and doing thyrogen injections, which are known as recombinant human TSH, which are injections that trick the body into thinking that you're not on thyroid hormone, but you are. The FDA approved for treatment both ways, for at least treatment of what's called remnant ablation, or getting rid of a little bit of thyroid tissue, or a local disease. It's not FDA approved for metastatic disease, but there are lots of places in the country that are using it for that purpose with good data that it works. So this is just a picture of what you're looking at when you look at a radioactive iodine scan. Actually, I can use the mouse. So usually it's the whole body. I'm just showing you the head and neck here, but you see the head shape here and the shoulders. Is that pointer showing up there? Yeah, okay. And so there's black is radioactive iodine uptake, meaning that's what they're calling lighting up or where iodine is going. So this is just a little bit of uptake in the thyroid bed where the thyroid was and probably some normal thyroid tissue. But you can see the scan's unclear. It doesn't tell you what's cancer and what's normal, so you just have to use your judgment. And this part here is what's called nasopharyngeal uptake. So this is normal uptake in the salivary glands. But you can see there's quite a bit of uptake. So you know that the salivary glands are getting hit. So everybody loses about 30% of the salivary production automatically when they get iodine. Most patients don't notice. Some will develop a dry mouth. So moving after surgery plus or minus radioactive iodine, then now we're giving the patient back their thyroid hormone and we're giving them a little more than their body needs to keep the cancer from coming back. So it is a form of anti-cancer treatment. So basically the TSH is the brain's perception of how much thyroid hormone you're on. And then your doctor probably measures free T4 levels, which is the amount of thyroid hormone your body's on. So you want the T4 to be in the normal range, or your thyroid hormone in the normal range, but you want the brain to think that you're on too much thyroid hormone. The brain's more sensitive than the body. So the goal is the normal range of the TSH is about 0.5 to 4, depending on what lab you're in, but you want your TSH below 0.5. But we found out that depending on what stage or your cancer is in terms of what risk you have of your thyroid cancer coming back, we keep the TSH in a certain range. So if patients who have stage 1 thyroid cancer, we keep their TSH between 0.5 and 2. If you're higher risk for your thyroid cancer to come back or you have what's called persistent disease, meaning you still have thyroid cancer there, then we keep your TSH between 0.1 and 0.5, so below the normal range. And if you have metastatic disease, we keep that TSH around 0.1. I'm sorry, I didn't explain when I say low, it means high. So what that means when your doctors are talking to you about things like that, so when you don't have a thyroid, the brain doesn't know the difference between being on thyroid hormone and not having a thyroid, okay? So if I cut your thyroid out and I don't give you thyroid hormone, the brain says, wake up thyroid, make more thyroid hormone. So the way it signals the body is that TSH goes high. So a high TSH means there's not enough thyroid hormone around. So it's the opposite of what you would think, okay? So if I give you thyroid hormone, and I give you too much thyroid hormone or more than your body needs, that brain is telling the thyroid, shut up, there's too much thyroid hormone around. So the way it signals it is that TSH goes down. Does that make sense? So I want TSH down as an anti-cancer treatment, meaning I want you on more thyroid hormone than your body needs. Okay, so we no longer advocate this TSH to be what's called undetectable. So you'll have a lot of patients who come and are, on so much thyroid hormone, either they have symptoms or their doctor said, no, this keeps your cancer away. Well, there's some recent evidence that, you can have increased risk of fractures and atrial fibrillation or irregular heartbeats, so if you're on too much thyroid hormone. So you want to find that balance with side effects and anti-cancer treatment. So how do we follow these patients up? So the ultrasound of the neck is a very sensitive way to catch recurrent thyroid cancer or if there's any thyroid cancer left. Especially if you're in an area where their ultrasound is very good. Again, they're doing ultrasounds of the whole neck, not just the thyroid. If you're in an area where there isn't very good ultrasound, CT neck is acceptable. I mean, it can find the cancer as well. It's just that you get some radiation. So the other way is that there's a blood marker, a protein in the blood called thyroglobulin, or TG. Thyroglobulin comes from normal thyroid tissue or from thyroid cancer. So somebody who has their thyroid intact or half a thyroid in their body still has thyroglobulin even if they have no thyroid cancer, right? We cannot distinguish the two with thyroglobulin. If you've had surgery, removed your thyroid, and had radioactive iodine, in follow-up, I expect that thyroglobulin to be what's called undetectable, meaning I can't find any evidence of that thyroglobulin. I can't find any evidence of that cancer. So I want that number close to 0. 20 to 30% of thyroid cancer patients, their white blood cells attack their thyroid, just like it fights off an infection. For some reason, it's chosen to attack the thyroid. So you get what's called thyroglobulin antibodies. So the thyroglobulin itself, or the TG marker, is not reliable, but you can follow the thyroglobulin antibodies. The difference is the thyroglobulin takes only a month to disappear after surgery and radioactive iodine to be able to tell somebody that there's no disease, but the thyroglobulin antibodies can take 3 to 5 years to disappear without somebody having disease. So it's a little bit harder to follow, but can be done. But we don't want patients worrying if their antibodies are positive and it's only 6 months after surgery. So to tell a patient that they don't have disease, we want the marker, not showing up in the blood, or the thyroglobulin antibodies negative, and their ultrasound to say that there's no disease. Most commonly, if the thyroid cancer comes back, it loves to come back in the neck. So ultrasound is the best way to follow it. Rarely will it go outside the neck, and we'll talk about that later. So we typically will follow patients twice every 6 months, times 2, and if there's no evidence of disease, they're on annual follow-up. Currently, we don't have good thyroid cancer survivor guidelines to say, what do we do beyond X number of years? So I'll tell you what we're doing at Anderson. We've formed a thyroid cancer survivors clinic that you've probably met several people that run it here. Johnny Rollins is the nurse practitioner who runs it. Lynn Waldman is the social worker who runs it. And they have different disciplines there that can help patients who may or may not have symptoms and or social or psychological aspects that they're trying to deal with. So even though the doctor says, yay, let's go celebrate, you don't have any evidence of disease, you may still have other issues that need to be dealt with. And they're following you for the thyroid cancer recurrence. So those patients are getting ultrasound and blood for every year for the first 10 years, and then they go to every other year. So thyroid cancer is highest risk to come back in the first 2 years. Second most common is within 5 years, and then after that the risk goes down, but it doesn't disappear like other cancers to go to 0 at 5 years. So that's why we do annual ultrasounds and blood work. So how do we define recurrent disease, meaning the cancer has come back? So there's one of two ways. We either will see something on ultrasound or CT that we can biopsy and say there's disease, or we can see the marker in the blood is elevated, the thyroglobulin or the thyroglobulin antibody. So some patients will have a thyroglobulin that's elevated, and the question is, what do we do about that? Well, the first thing is we shouldn't panic, right? And we see this from both patients and physicians, because everybody wants to have the cure, which is obviously our ideal, but we also treatments can harm patients. So you want to find that balance. So if patients have had surgery and radioactive iodine, and in follow-up, their thyroglobulin is still not gone to 0, we'd say, yes, there is still some what's called persistent disease. You still have some thyroid cancer. We would do the ultrasound. If we don't see any disease there, depending on the level of the thyroglobulin, we may look for disease outside of the neck, which would include a CT chest. And if we don't see anything, then the patient has persistent disease with the thyroglobulin, but we're not seeing anything. So now it becomes just a number, but we're treating the patient. So if the ultrasound of the neck doesn't show disease, but the thyroglobulin of the cancer marker is elevated, after doing some other tests, we then will continue to watch the patient. It's okay to observe the patient and not try and do more surgery or more radioactive iodine or any other treatments, but just watch what happens to that marker. Sometimes it continues to remain the same. Sometimes it goes down. If it goes up, then you know, okay, we need to do other things. But if it's staying around the same level, then you want to tell the patient that, yes, you have some thyroid cancer. We cannot find it. Currently, it's not going to cause a problem in the immediate future, so we have to follow this because my treatments could harm you. So we turn around and give the analogy of the moss on the tree, right? The tree doesn't like necessarily having that fungus or moss on there, but they're living with it symbiotically, and that's kind of how we change our mindset sometimes with thyroid cancer, because we can harm with our treatments. If the ultrasound of the neck does show disease that we can see, we biopsy and prove that it's thyroid cancer, and it's either in an area that can be threatening if it grows, or it's in an area where the surgeon says, I can easily remove this, then why not go for the cure? So surgery is the best chance at cure, even when it's come back, if you can see it and prove it on biopsy. What you don't want to do is go to the operating room when you haven't proven that it's disease, because you can have other things in your neck other than thyroid cancer. So we talked about how do we actually look for the disease. The thyroglobulin tells us whether or not there's disease, and then the ultrasound of the neck. Those are always done in thyroid cancer patients, or sometimes a CT neck if you don't have good ultrasound. But then if you have this persistent elevated thyroglobulin, you didn't find anything in the neck, you may want to look in the chest, because second most common place for thyroid cancer to go outside of the neck is into the lungs. Radioactive iodine scan is done. One time, if you have an elevated thyroglobulin, still can't find the disease, or even if you can find the disease, you want to see if it takes up radioactive iodine. So sometimes the thyroid cancer will come back, and if it takes up radioactive iodine, you can use more radioactive iodine to treat it. But if it doesn't have light up on the radioactive iodine scan, then you say, okay, we have a high thyroglobulin, meaning we know there's disease, but the iodine scan is not lighting up, so you have thyroid cancer that's resistant to radioactive iodine. So continuing to treat you with radioactive iodine will not work. Does that make sense? So, and then if you have very elevated thyroglobulin levels, rarely will you need a CT abdomen, a bone scan, or an MRI of your brain or spine. Those are very rare. So what about PET CTs? PET CTs are very good for many, many cancers, and so patients always I want you to look throughout my body for any cancer. Well, one of the good and bad things about thyroid cancer is very often the thyroid cancer does not light up on a PET. Okay, so what a PET CT does is it takes the CT scan that you're used to, which is the anatomic, meaning I can see the shapes, and the PET scan is taking sugar, making it radioactive, and injecting it in your body. That sugar loves to go wherever there's, in general, where there's metabolically active cancer and or where there's infection or inflammation. There's other things that can light up on a PET. Now, for some cancers like lymphoma, PETs are great. With thyroid cancers, a lot of them are not very metabolically active. So we could biopsy your thyroid, find a thyroid cancer, and the PET scan could still be what's called negative, meaning it's not lighting up. So that's good because you don't want a very metabolically active cancer, but it's bad in terms of making it hard to find. But we know that the more aggressive thyroid cancers do light up on PET scan, and that the more spots that one sees on the PET scan, the more aggressive the cancer tends to be. So when do we use PET CT in thyroid cancer? If the thyroglobulin is above 10 and we don't find it on any other imaging, we'll often order a PET. And that's the same indication that the insurance companies or CMS will pay for. Rarely, there are patients who don't make thyroglobulin, and they're what's called poorly differentiated. Their thyroid cancer is considered a more primitive or more aggressive thyroid cancer, and they may not make thyroglobulin, but we'd still get a PET scan. So there may be exceptions to the rule that's written up there. So what is recurrent disease, and how do we define it? So disease that's persistent in the neck, meaning it's still left there. So if you had surgery and radioactive iodine, your thyroglobulin continues to stay there. That's called persistent disease. And recurrent disease is when my thyroglobulin went to zero, the ultrasounds were clear, I was told I had no disease, and now my thyroglobulin's climbed and I see disease there. So about the good news is 85% of patients after surgery plus or minus radioactive iodine are cured, and their thyroid cancer never comes back. But about 15 to 20% of patients with thyroid cancer, their thyroid cancer will come back, and most of the time when it comes back, it comes in the neck. If one has what's called small volume disease, meaning a smaller size disease that's not growing and not changing, it's not in an area that the surgeon feels is threatening anything, then these are patients where we can say, let's watch this disease. No, I know nobody likes to hear that, but sometimes, again, we need to find out what's happening with the disease, make sure it's not growing anywhere else, and we're not sending you to the operating room when you don't need to go. Or two, for the surgeon may tell us that surgery is too difficult. So there are reasons why we sit and observe disease in the neck. If the disease is growing or in a threatening area, we're going to talk about surgery and or rarely systemic treatments or pill-type chemotherapies. So I think we talked about this already. If thyroglobulin is elevated, ultrasound doesn't show disease, those are patients we can watch, or if it's small disease where the surgery may miss removing all of it. So sometimes we'll see 4 millimeter, 6 millimeter, we know it's disease, we've biopsy proven that it's disease, but they've done multiple research papers to show, let's say a patient had a thyroglobulin of 15, had small volume disease on ultrasound, the surgeon went after that, after the operating room, the thyroglobulin now is 10. So what did I say it was before, 15? What was my example? 15? So if it went from 15 to 10 or 15 to 8, did we really do you a favor? And so multiple times, yes, okay, we're all happy the marker's down, but you still have disease. And now we sent you to the operating room, put you under anesthesia, and potentially can cause complications, right? You've all seen patients with thyroid cancer who have complications from surgery. So we always have to think is what is our goal? And that's why the question came up at the beginning. So how do we watch patients that we've now told, okay, there's disease in your neck, but we're going to watch it. We can't take it out for whatever reason, the reasons we outlined before. We tend to do imaging of the neck, which is ultrasound or CT of the neck, Initially we may do 3 to 6 months, and then we go to every 6 months to continue to watch. Because what can happen with thyroid cancer is you can have stable disease, meaning it's not growing, and then it climbed a few millimeters, but then it was stable. So you want to know what's happening over time in patients who have what's called recurrent or persistent disease. If you see thyroid cancer that continues to grow and the graph is looking like that, then that's a different story. This is somebody you need to do something about. Whereas the person who's stable and slowly growing over years, perhaps we don't need to do something, especially if we don't think we can cure them, right? Because the goal is cure with a good quality of life, without side effects. If you just followed with ultrasound of the neck, then I recommend at least one CT, especially in the recurrent disease, just to make sure there isn't something behind what the ultrasound can actually see. What about the role of radioactive iodine in recurrent disease? So so you can do the one radioactive iodine scan that we talked. So let's say you've been treated with radioactive iodine, the thyroid cancer now has come back. If you know that there's disease in the neck, you can do one radioactive iodine scan, knowing that there's disease there. So there's 2 ways to do it. One is I just give you an empiric dose and I treat you with radioactive iodine, okay, meaning I know there's disease there. I'm going to go ahead and treat you with a dose of radioactive iodine, but then I should do what's called a post-treatment scan, a whole body scan where I look if the tumor or the cancer that I knew was there takes up radioactive iodine. And if that post-treatment scan is what's called negative, meaning it doesn't show up radioactive iodine, then you and your doctor should be talking about closing the door on any radioactive iodine treatment. Too often what we see is they'll get the radioactive iodine treatment, and the post-treatment scan or the scan after the treatment is what's called negative, doesn't show up any iodine, and then 6 months later they're getting another dose of iodine, a year later they're getting another dose of radioactive iodine. We've already determined from that one empiric dose that your thyroid cancer is resistant to radioactive iodine. Does that make sense? So one empiric dose is okay, and this will be even in the new guidelines. I think it's even in the old guidelines. One empiric dose of radioactive iodine is okay. If your disease lights up, it's fair game to try another one, within reason, depending on what it showed up. If the disease did not light up on the radioactive iodine when you had known disease, then there's no need to give any more. What some people might do is do what's called a diagnostic scan. It's not very common, but it's a baby dose of radioactive iodine when you know you have disease to look if there's any radioactive iodine uptake. And if they don't see anything there, then they don't treat you. So that's another option. So what about metastatic disease or disease outside of the neck? So metastatic disease was typically considered anything like lungs, in most common after the neck, and then bones rarely, and rarely would it be belly or brain. So what we do know is shown on this graph. All we're trying to show is that, yes, patients who have what's called stage 4 disease, so patients over the age of 45 who have thyroid cancer that's very advanced in their neck or is outside of the neck, do have a shorter survival than patients who have disease that's localized in the neck. But not all stage 4s, not all stage 3s, not all patients with stage 3 or 4 disease are created equal. This is a beautiful slide that I got from Dr. Mike Tuttle in Memorial Sloan Kettering, who shows what is on the x-axis, you can see there is the normal lifespan. The red y-axis on the right-hand side is the goal line, and then the y-axis on the left side over here is the volume of disease. Oops. So patients who have anaplastic thyroid cancer don't reach their goal line in general, okay, and they have a shortened lifespan. Patients who have thyroid cancer that is responsive to radioactive iodine, meaning their thyroid cancer gets treated with radioactive iodine, tend to reach their goal line, and we can shrink the disease, right? So they have what's called better behaving thyroid cancer. But there are patients who are resistant to radioactive iodine who behave very differently from each other. It's not all the same. So that means these patients who we've determined still have persistent disease, but they don't take up radioactive iodine, so they're resistant to radioactive iodine. Some of them may reach their goal line. Some of them may reach their goal line with cancer growing. And some of them may have their cancer growing at a faster rate, but they don't reach their goal line. So we have to do a better job of trying to predict how patients are going to do so we can go for that cure from the beginning. Either be more aggressive from the beginning, give multiple treatments, or whatever we have to do to help everybody reach the goal line. Does that make sense? But we can't sit there and tell every patient with stage 4 that is resistant to radioactive iodine what their outcomes are going to be, because we don't understand the disease. So what do the guidelines say? So patients who have metastatic disease that is either stable, meaning not growing, or growing very slowly, then just continuing them on a little more thyroid hormone than their body needs is the treatment. We should not jump into any other treatments. And why is that? Because we don't have the cure for those patients. We're working on the cure. One day we will have the cure, but for now we don't. And so sometimes the treatment is more harmful than the disease. So those patients, we continue them on what's called TSH suppression, a little extra thyroid hormone than the body needs to keep, and it does work at keeping the cancer at bay. So how do we follow patients who have metastatic disease that's persistent? So if they have disease in their lungs called lung metastases, then we do CT chest every 3 months initially, times 2, and if they're stable, then we go to every 6 months. And if they, and then after that, we do CT chest every 6 months. Of course, we're doing thyroglobulin and blood work. So we're not just doing thyroglobulin, we're also doing imaging. And then there are those patients whose lung metastases are slowly growing. Then we would probably do CT scans every 3 months initially, just to make sure we understand the trajectory of the disease. Is it one of those that's doing this, or is it one of those that's doing this? Because the treatment for those 2 patients are very different. So what are the, and in another session, you're going to hear about metastatic disease from several people. So I just want to share with you the guidelines from both the National Comprehensive Cancer Network as well as the American Thyroid Association said that for patients who have disease that's growing, that's progressing, then we should consider putting them on a clinical trial or a drug that's in research that we think has biologically we think has reason to work, or put them on one of the 2 FDA-approved drugs known as lenvatinib or sorafenib, or put them on some other small molecule inhibitor. And don't forget, if patients have metastases, it's not always chemotherapy. It may be if they have an area of the thyroid cancer that's in the bone or the brain that they have surgery for it, or radiation for specific sites. So coming back to those questions we asked at the beginning, questions to think about. The goals should be personalized. What do you personally want for your thyroid cancer, and understanding what is possible with the current treatments and what are the side effects. So what are our goals and what are the side effects? And then how many surgeries have I had, and what would happen if I have more surgeries? What are the potential complications? How many radioactive iodine treatments have I had? Did my disease respond to the radioactive iodine before or not? And then finally asking the surgeon how many thyroid cancers they do, and asking your endocrinologist or your oncologist how much thyroid cancer they see, especially if you have something beyond the initial disease. But even at the beginning of diagnosis, understanding these things are very important. And then the questions we talked about, what to ask. At diagnosis, how much surgery do I need? Will this surgery cure me? And did you look at my whole neck and the lymph nodes? And then after surgery, do I really need radioactive iodine, and how is it exactly going to help me? And then on my thyroid hormone, what is my goal for my TSH? Where do you want it? How much thyroid hormone do I need to be on? How often are we checking labs? So with that, I wanted to leave some time for questions, and I wanted to just acknowledge that this is, it takes a team to treat thyroid cancer, the patient being in the center of it, which is you all. But there's surgeons, endocrinologists, oncologists, radiation docs, research docs doing clinical trials, pathologists, nurses, mid-level providers, radiologists. So it's a bunch of docs, and without any one part of this, this can't work. So with that, I want to thank you, and I'll leave you there with my email and phone number. And if you have any questions, I think Evelyn's asking that you come to the center microphone, because it is being recorded.
Okay, I'll ask the first question. That's great. Sorry. Both at the beginning and at the end of your speech, you mentioned about how many surgeries the surgeon has performed, thyroid cancer surgeries. What is your best recommendation for how many should they do? I mean, if I go in and he says, I do, 10 a year. Is that good? Or do we want him to say 100 a year? I mean, what do we want him to say?
Yeah. So, I'm not saying somebody who does fewer surgeries is necessarily a bad person. So this is not to any one person, but it's even written in the guidelines that a patient, a surgeon who operates and does thyroid cancer surgeries over 100 a year is considered somebody who does high volume thyroid cancer surgeries and is somebody that you should seek out. So you might do just fine with somebody who does less volume, but in general, the research shows because this can be complicated and you want the surgery is the best chance at cure, you want to go see that good surgeon who has those numbers behind them.
I'm curious about the body scans that you get after the fact. Like I've had many body scans with the baby doses of radioactive iodine. Mm-hmm. What are your thoughts on the safety of those baby doses of radioactive iodine and the radiation from the actual body scans?
Okay.
If I've been clean and my blood work is good and I just don't see a reason for it and I fight with my doctors every time.
Mm-hmm. Keep fighting.
Yeah.
You're on the right track. Keep fighting. So I'm not going to repeat the question, right? Because she's using the microphone. Everybody can hear? Yeah? Okay. So I'm going to divide your question into two parts. What is the role of the radioactive iodine, what's called a diagnostic scan, which is the baby dose scan, in the follow-up of the thyroid cancer patient? And to be fair, the whole body scan was used as part of the diagnostic criteria of recurrent disease or if disease has come back. And what we used to say is if you have a whole body diagnostic scan or a baby dose scan times 3 that don't show up disease, and your blood test called thyroglobulin doesn't show disease, then you can say that you don't have any disease. We no longer do that, and that's been removed from the guidelines. So what we do now is that we say thyroglobulin is more sensitive a marker for the vast majority of thyroid cancer patients than the whole body scan. And so we're using the ultrasound of the neck and the thyroglobulin to follow these patients. And if the thyroglobulin rises, there may be a role either for a baby dose or an empiric dose of treatment of radioactive iodine, or other imaging or treatment. But to just repeat, the whole body scan is no longer done as a way to diagnose recurrent disease. The second question you asked was the safety of the baby dose. So the good news is the baby dose, the diagnostic whole body scan, gives very, very little radiation, that it's fine, it's safe. It's just irritating that you have to go on a low iodine diet and either get those thyrogen injections and or get in the time off from work. So from that point, it's damaging, but medically speaking, from radiation, you're okay.
How does a patient learn about clinical trials? I mean, do I rely on my endocrinologist to know about trials that are going on all over the country, or should I do my own research to find out about clinical trials?
Come to my next session. No. No, it's a very good question. So I advocate patients to be their own advocate. And if necessary, I'm never afraid if my patients ask me to go for a second opinion, because I think it's important that the patient's comfortable, right? So there's two ways to do it. One is there's a website called clinicaltrials.gov, www.clinicaltrials.gov. That's a good resource. You can type in there, let's say you just want to know what's in your state. You could say thyroid cancer and California or whatever. If you wanted to be specific, you could put differentiated or papillary, but I tend to type general, especially where my patients live, to see what may be available for them. But you can just look up thyroid cancer, and all the trials in the country can show up. Some of them are surgical, some of them are radioactive iodine, some of them are for distant disease. And so, yeah, it's great if you could rely on the doctors, but I definitely, especially in this day and age of internet and having easy access to these things, I advocate my patients to look things up. The other is the American Thyroid Association website tries to keep up with the trials available. Just because I work at MD Anderson, I'm going to also tell you that at MD Anderson, we have all the clinical trials listed there as well. So any of those websites are excellent resources. And you can be as specific as you like, depending on what you're looking for. Does that connect into, there's a link? Yeah.
Hi, I'm Kathy from St. Paul, and I have a question. For recurrence of papillary cancer, thyroid cancer, I'm wondering if you could talk a little bit about the rate of growth of the tumor, and because we always hear that thyroid cancer is a slow-growing cancer. What are the time spans and the sizes, and if that's aggressive, not aggressive, that sort of thing?
Okay, so great question, and you're asking specifically with papillary thyroid cancer. Yeah, so when you think about, first of all, I absolutely hate when doctors say this is the best cancer that you could have, which is slightly different from what you said, from what you were saying, people say, but, obviously those people have never had cancer, right? So it's completely irrelevant, and there's a nice quote from the ThyCa website that I actually got about that. But in general, papillary thyroid cancer tends to be a slow-growing cancer. That part is true. So when most people are diagnosed with their papillary thyroid cancer, they may have had it there for 5 years, 10 years. We don't know how long they've had it, and it's typically incidentally found. I had an MRI for my neck pain or carotid ultrasounds at a health fair or what have you, and a nodule's found, and that's typically how it's found. So most patients are asymptomatic, and it has been growing for a long time. But once you're diagnosed, I'm assuming you're saying somebody who's had surgery plus or minus radioactive iodine, they have some disease that's persistent or there, then when we follow it, how do we decide what's a progressive or a fast-growing cancer versus a slow-growing cancer? And so in general, we use two things. We use, this data isn't as strong as with medullary thyroid cancer, but we use what's called the doubling time of the thyroglobulin. So if you follow the thyroglobulin when you're coming back either every 3 to 6 months, depending on the growth, which part of the follow-up you're at. Let's say you're at every 6 months, and every 6 months you come and thyroglobulin is going from 5, 6, 5, 6. We have patients that sit like that for years. Then you're considered a slow-growing. If you have that it's, 5, 10, 15, 20, and every 3 to 6 months you're seeing that rise, well, maybe you don't need treatment right when it's gone from 5 to 10 to 15 to 20, but now that I'm looking over 3 years, I'm saying, you know what, this is growing at a fast, of course, that I'm using imaging, not just thyroglobulin doubling time, at a fast enough rate where it's bugging me. I'm worried about you getting into trouble. I'm worried about something happening. Or if on imaging I'm seeing it grow, even if the thyroglobulin is not increasing at a faster rate, but I'm not talking millimeters over 5 years. So sometimes what happens is a patient will have a CT scan of their neck, and it showed that they had an 8-millimeter lesion, and then they disappear for 5 years, and they come back, and now it's 1.5 centimeters. Well, that took we don't know, either took 5 years to grow, or was stable for 4.5 years or 5 years, and then it just took off. So without knowing those time points, no one can say how fast that grew. So if you've been having follow-ups every 6 months, and things are just millimeters, little up in thyroglobulin, then maybe you don't want to interfere. Does that make sense?
What if it just shows up?
So there was nothing there, and then something shows up. So first you want to make sure that it's disease. You can either you do a biopsy, you can even, if the biopsy can't tell, you can do what's called a thyroglobulin washout. So they measure the thyroglobulin in that, whatever they biopsied, and compare it to the thyroglobulin that was found in your blood, to be able to say if it's disease or not. And if you've proven, and the reason I say that over and over is because there are plenty of patients who have other diseases that pop up. So we always want a biopsy before we do something about it or say that it's thyroid cancer. And then if it just popped up, you have two options. One is to talk to the surgeon, depending on the size, to see if it can come out. You can evaluate it with radioactive iodine, or you can wait till a shorter next follow-up to determine which way it's going.
So my question is about monitoring thyroglobulin if you have antibodies, the Hashimoto's or the thyroglobulin antibodies. And what are your thoughts on the mass spec thyroglobulin test for those of us with antibodies? And my personal example is I had Hashimoto's and still have thyroglobulin antibodies. At 1 year follow-up, there was sort of a discordance of opinion between nuclear medicine on the one hand, who said recurrence, your thyroglobulin is 5, even unstimulated, and but that was by the radioimmunoassay type of assay, and the antibodies are still present in 20s or so. But my endo, who also did a test over with the Quest diagnostics mass spec test, not detectable, and no clinical evidence of any other recurrence, and said, no, that's not a thing. And I tend to believe my endo because this test is newer, and we know that when we're looking at someone with antibodies, that some of the traditional tests for thyroid globulin are not reliable. So your thoughts on mass spec test versus other tests?
Okay, I have 2 questions for you, if I can give you questions back. Number 1, that's a number. You're a patient. Why do I care who's right or wrong? Number 1. Number 2, and you can come to that. Number 2 is, what am I going to do about it? If I don't see disease and it is 5, then what? I'm going to panic. I'm going to have anxiety. But have you helped me? So that's how I first step back. When patients always come, because the problem is the doctor causes the anxiety, in my opinion, right? Because we have a number, we all want 0. That's fantastic. We all want to be told we're cured. We want to hear that. But at the end of the day, sometimes our tools are too sensitive, and we're picking up things that may or may not be disease, but you're causing a disease in me now. I'm now anxious, hypertensive, I can't sleep, and I'm probably going to die of that. I have to, and this is how I frame it to the patient. So, yes, there are all sorts of theories. People get up in the American Thyroid Association and all these other societies, Endocrine Society, and they argue back and forth about should we use mass spec, should we not. All this money is spent in doing all this, but at the end of the day, what I want the patient to remember is, how does it affect me today? What is it going to do for me? And if the doctor's telling me, yeah, it's 5 and you might have disease, but I can't find it and there isn't anything I can do about it, was it worth all that fishing? And maybe it is to you.
Well,
but I think it's important, remember, we understand our goals and what are the side effects. I don't want anybody digging in my neck or treating with radioactive iodine for a 5 that may or may not be true.
Well, and that was exactly I agree with exactly what you're saying. So the mass spec test was negative, the older test was positive, and I rejected the offer of additional radioiodine. So that was but it is also for a patient, a situation where someone with an MD and who sees 700 thyroid cancer patients a year is saying, hey, you have recurrence, here's more treatment, and so what you're saying about anxiety is kind of well, somebody's just given you a diagnosis basically, and you're supposed to do this treatment, but my personal tendency was to believe the newer test, and I was just curious if you have thoughts on, or if the guidelines are speaking to that as a newly valuable test, if we do have still the antibodies.
They may or may not. We can't say what the final guidelines are going to say, but does anybody know if Dr. Spence is coming this year? She comes and talks about thyroid globulin assays usually. Does anybody know? Yeah. She's not coming this year? Okay. So I was going to say that you should sit and talk to her because she also feels strongly about some of those things. But I'm not downplaying the idea that cancer may not be there. So don't get me wrong. I think there is a controversy there, but I want the patient to drive the physician in those instances exactly what you did, which is great, I believe you, but I don't want you to be aggressive if you're not even sure it's going to help or not. That was my point. I'm not trying to downplay the fact that whether or not you have cancer is important. That's very important. But at the same time, changing our mindset so that we can live and have a good quality of life is important too. That's my only point.
Hi, 2 questions. First, do you know when the new guidelines are going to be coming out?
I was told 2013, then I was told 2014, but it's 2015, almost done. So medullary thyroid cancer guidelines just came out a few months ago, so I think that's a good point in the right direction, that the differentiated will come out soon, but we do not have a...
I heard it's going to come out at the ATA.
Yeah.
Which is...
It's October, I think, 18th to 23rd.
Okay, thank you. The other question was earlier...
I'll wait till they're out. Evelyn's positive.
Sure.
It should. It was very close to finish.
Okay. Thank you. And an earlier slide, you were, I think, trying to explain that the RAI is not mopping up the cancer cells. Instead, you were drawing a connection between the RAI and the recurrence and the survival rates. Mm-hmm. Could you elaborate on that just a little bit? And my understanding had always been that the RAI, the purpose was to go in there and hopefully zap the cancer cells. So maybe I'm misunderstanding something.
No, you understand perfectly correctly. So I'll just clarify. I wasn't clear. So what I was trying to say was that, okay, so first of all, you're absolutely correct. So radioactive iodine is a targeted therapy. It goes after the cancer cells and normal thyroid cells, anything that is a follicular cell that has a potential to make thyroid hormone. It gets in there and the radioactivity kills it. You're absolutely correct. Patients who have metastatic disease, that is their best chance at cure. I mean, of course, after surgery, et cetera, it goes into those sites and zaps them, and you can actually, there are patients who you can cure with that. Okay. What we don't want is when you have larger volume disease, okay, so even whether it's metastatic or metastatic distantly or in the neck, so somebody who's had incomplete surgery, so has still large lymph nodes, okay, radioactive iodine isn't very good at killing things bigger than a centimeter. So if you just had somebody remove your thyroid but left a 1.5 centimeter, 2 centimeter lymph node in there, we don't want, when you see the endocrinologist and they go ahead and they say, okay, we want to treat you with X amount of radioactive iodine, and then you see this thing brightly light up, the chances are you're going to have what's called persistent disease. You're still going to have an elevated thyroid globulin. So you don't want to keep treating with radioactive iodine to mop that. That's what I mean by mop up. Surgery is better to go back in and remove those lymph nodes. So if you have a suggestion of that or a hint of that before you've even done the iodine, like you think, wow, this, like sometimes you'll go see you've had surgery, you go meet the endocrinologist and they'll do a bedside ultrasound, they'll see, I see lymph nodes here, then I would halt the process there, not do radioactive iodine, send them back to the surgeon at some point. It doesn't have to be right away. It could be within 3 months or whatever, and have more surgery before iodine, because the biology of the radioactive iodine doesn't work very well. So that's what I meant. I just didn't explain it properly. But you understood it completely correctly.
My question relates to whether or not you've ever seen a situation where the pituitary gland stops producing TSH. I've been on a suppressive dose of Synthroid for 45 years with suppressed TSH, and lately my TSH is 0, no matter what both at 200 Synthroid and at 175 Synthroid. Is there any evidence that what I started asking is true, that the pituitary just finally gives up and says, hey, this guy doesn't need me anymore, goodbye?
Yeah, so very good question. But there's two possibilities with the scenario that you described. So to answer your question, yes, there is a possibility that the pituitary, so what he's referring to is that TSH, when I was telling you the brain's perception of the thyroid hormone levels, comes from a gland in the brain called the pituitary. It makes 6 hormones that are important for controlling other organs. TSH is one of those. So sometimes somebody's had radiation to the brain, or for whatever reason, there's multiple reasons why pituitary may not work, and then you're not making any TSH. So in those people, if I completely stop their thyroid hormone, I would see their T4, their thyroid hormone levels go down, but I wouldn't see their TSH necessarily budge. However, the risk of that is very low. Okay, it can happen, definitely, and that it should be investigated. The scenario you're describing, where the dose of thyroid hormone was lowered by 25 micrograms from 200 to 175, may be something else, and where you didn't see the TSH budge, may not necessarily be that my pituitary is working. With age, graceful aging. I'm aging too, it's all good. We tend to require less thyroid hormone than the body needs. So when we start out with a diagnosis of thyroid cancer, we tend to replace thyroid hormone at 2.1 micrograms per kilogram of body weight. By the time where, even 60, 70, we can require less than that to continue to suppress the TSH. So it may be that either that we're requiring less thyroid hormone and we have to go down by more than 25 micrograms, so he'll be successively going, or she will be going successively lower down on your thyroid hormone. Or the other thing is drug-drug interactions. So there are many medications that can interfere with thyroid hormone. Some accelerate the metabolism of thyroid hormone, which means you end up needing more, and some can decrease the metabolism of thyroid hormone. It hangs around longer, so you end up needing lower doses. So there's a couple reasons more common than a pituitary dysfunction that may occur, but you're absolutely right. I mean, obviously the pituitary could be problematic, but I would try those other things first because they're more common.